Yeah, okay. So it's three, two, one. We are running to the audience. You can start the session. Over to you, sir.
Yeah. Thank you. Thank you, Lupin, firstly, for this chance to speak about one of my pet topics, prostate cancer. So I am Dr. Vishruth Raj. I am a senior specialist urologist and uro-oncologist from Bangalore. Currently, I'm working at Aster RV Hospital and Sri Shankara Cancer Foundation as a uro-oncologist and a robotic surgeon. So why prostate cancer? Of all the many topics which Lupin Pharma offered me, the reason I have chosen prostate cancer, obviously, is because it's one of my pet topics, but more importantly, because it is one of the most common cancers in men across the world. On that note, let's find out a bit about the prostate gland firstly. I'm sure this is a bit of a basic thing. Most of you know this already, but nonetheless, just a revision that it is a accessory sexual organ which is present only in men. It is situated immediately below the bladder neck and it encircles the urethra, which is also called the prostatic urethra. So the function of the prostate is to produce fluid which nourishes the sperms and thus makes up a significant portion of the seminal fluid. So once a man has completed his family, then the prostate gland becomes predominantly vestigial, just like the appendix. It does not have much of a function once a person has completed its family. Unfortunately, for all men, even though it does not have any function, it can produce a lot of problems. One of the most important of those is prostate cancer. So let's start with a bit about the epidemiology and what causes prostate cancer or the etiology. So this is a study which is about 10 years old, which concentrated on the most common cancers in men in India. Most of the data available about prostate cancer is all data from the West. And this is one of the earliest studies which focused on the various cancers in men in India. As you can see, prostate cancer was somewhere in the middle of these common cancers, second or third only to cancers of the oropharynx and the lung. But this is a study from 2012. In the last 10 years, prostate cancer incidence has increased exponentially in India, especially in the metropolitan cities, where the awareness about prostate cancer and the increased screening has therefore increased the number of cases of prostate cancer. And right now, at the moment, as per the latest data, prostate cancer is the second most common cancer in men after cancers of the oral cavity. So what is the age during which you usually get prostate cancer? More often than not, problems from the prostate, especially benign enlargement of the prostate, as well as prostate cancers, they used to be disease of the older population. More often than not, you would see these cases following the age of 60 years. And as age advances, the incidence of prostate cancer also increases. In fact, in one of an autopsy series which were done in men who had crossed the age of 100 years, the incidence of prostate cancer was close to 100%. So what that means is, as you age, the longer you live, more are your chances of developing prostate cancer. That is point number one. But the more important, unfortunate thing is that recently we have been seeing lots and lots of prostate cancer patients in men when they have not even crossed the age of 45 years, around 40 years, 50 years. So the average age of incidence is decreasing. So this slide clearly shows the older data. From the age of 45 to 50, the prostate cancer would be around 23 per 1 lakh incidence, and 65 plus, it increases in leaps and bounds to 1000 per 1 lakh people. This ratio is getting slowly skewed now. The incidence in younger age group is increasing exponentially. So coming to the etiology, what causes prostate cancer? When we think of any cancer, we always want to know what causes the cancer. And unlike a few cancers where there are very specific risk factors, for example, bladder cancer, where smoking is the most common risk factor, unfortunately in prostate, there is no real identified risk factor as of yet. Age, I already covered this. As a man increases in age, the chances of him developing prostate cancer is higher. Race and ethnicity, this is more of an American data. It's supposed to be more common in African American men and in men of the Western hemispheres. Family history is very important. If there is a first degree or a second degree relative with prostate cancer in your family, then the chances of you developing prostate cancer increases by 2 to 4 times. So family history is very important, and usually in family history, in the offspring, the prostate cancer tends to be more aggressive and tends to occur at a younger age. Family history is mostly driven by genetic abnormalities, most commonly in the BRCA1 and the BRCA2 genes, which are also seen with breast cancer. High fat diet is also considered to be a contributory factor, especially a diet rich in saturated fatty acids, or in other words, a very Western kind of diet. Moving on to the evaluation and the diagnosis of prostate cancer. Let's start with what are the symptoms. More often than not, prostate cancer, especially early prostate cancer, will not have any symptoms. This is one very unfortunate thing. And because of this reason, most of our patients tend to present to us in an advanced stage. But of course, this is changing now. More oftenly, the symptoms that a male will come to you in your clinics or in your OPDs will be lower urinary tract symptoms. There can be an increase in the frequency, a weak or an interrupted urine flow, some pain or dysuria while passing urine, nocturia, or even hematuria. These can be the vague symptoms or lower urinary tract symptoms, which can be the initial presentation. However, once the prostate cancer becomes advanced or it becomes metastatic and spreads to various organs, then we can have some specific symptoms like spinal cord compression, pathological fractures of the spinal bones, bony pains, which are somewhat specific for prostate cancer, and the other symptoms of cancer cachexia like weight loss, loss of appetite, anemia, and bone marrow suppression can also be seen. So, but very important to remember that early prostate cancer will have very little to absolutely no symptoms. And just by symptoms, we cannot distinguish prostate cancer from many other conditions. So let's assume that a patient has come to you with some urinary tract symptoms. What do you do next? So obviously, clinical examination of the patient is extremely important. We have to do a digital rectal examination of the patient where we feel the surface of the prostate. This is absolutely mandatory for all gentlemen presenting to any clinic, to any doctor with urinary symptoms. More often than not, when we palpate the surface of the prostate gland, we can see some hard nodules in the prostate, or the two lobes of the prostate can seem uneven. The very first sign of prostate cancer is lobar asymmetry. One lobe can be softer or harder than the other, or in cases of advanced disease, the whole of the prostate can be uniformly stony hard, or there can be hard nodules felt in the prostate. But again, in 20 to 25% of the men, the digital rectal examination will reveal that there is a completely normal prostate, but in fact, they will be harboring prostate cancer. So what do we do next? Let's assume that there is a male who has come to you. There is a suspicion of prostate cancer. You have examined the patient. The next step is to do a PSA blood test or a prostate-specific antigen blood test. So the prostate-specific antigen is produced by the cells of the prostate gland, and this PSA test measures the level of PSA in the blood. So most labs report this PSA range, or most textbooks give this range as 0 to 4 nanograms per deciliter. However, one very important thing we should know about PSA is that PSA is only organ specific. It is never pathology specific. What I mean by that is many conditions related to the prostate can cause an elevated PSA where the patient will not have any cancer. So some of these conditions are prostatitis, that is inflammation or infection in the prostate. Benign enlargement of the prostate itself can cause elevated PSA, urinary tract infections, urinary catheterizations, sometimes even masturbation can also cause an falsely elevated PSA level. So just because your patient has an increased PSA, it does not always mean that the patient has prostate cancer. This is a very important thing to remember about PSA. However,
Sir, you sorry for the interruption, but your screen is not visible. I mean, you haven't shared your screen.
oh,
Can you please share your screen?
do you want me to start over?
No, it's fine. Just just share your screen.
Is it seen now?
Yeah, it's visible now. Visible. Okay.
Okay. Just apologies for that technical glitch. However, I was just saying that prostate-specific antigen blood test very important to diagnose prostate cancer. So just because there's an elevated PSA, it does not always mean there is prostate cancer. It can be increased in various conditions of the prostate, like prostatitis or benign enlargement of the prostate, urinary tract infections, even after masturbation or even after any kind of ejaculation will cause an increase in the PSA. However, there is some correlation. So, like I said earlier, 0 to 4 nanogram per deciliter is the value that most labs tend to report as the normal range. So, once there is a value between 0 to 2, there is a 10% chance of prostate cancer on biopsy. And this keeps on increasing as the PSA becomes higher and higher. If the PSA level is greater than 10, then there is almost a 40 to 65% chance of detecting cancer in the prostate biopsy. So the reason I have put this slide is just for you to understand that just because a prostate is in the PSA is in the normal range on a blood test, it does not mean the patient cannot have cancer. So very clearly seen in the very first column, even if the PSA is between 0 to 2, there is a 10% chance of prostate cancer on biopsy. So it is not a very specific test for prostate cancer, but it is the only reasonable and affordable test available right now, and which is used as a screening test for prostate cancer. So any patient coming to your OPD with any kinds of urinary symptoms, it is mandatory to do a digital rectal examination to palpate the surface of the prostate gland and to get a PSA blood test as part of a routine checkup. So let's assume that there is some suspicion. You have done a digital rectal examination, there is some variable consistency in the prostate lobes, or there is a hard nodule, or the prostate feels stony hard. And or if the patient has come with a PSA report saying the PSA is high, what is the next step? So the best way to make sure that there is a cancer in the prostate is obviously to do a biopsy. So for prostate, we do what is called as a transrectal ultrasound. So here a transrectal probe is inserted through the rectum, and under image guidance or ultrasound guidance, usually 12 cores are taken from different areas of the prostate in a systematic manner. So worldwide, the standard for prostate biopsy is to do a transrectal ultrasound guided 12 core biopsy. If there is a gray area or a gray level of prostate, which we call as 0 to 10, or a very small lesion in the prostate, then we may need to take multiple cores, sometimes even more than 15 or more than 20, which is then called as a saturation biopsy. So once we do the biopsy and send the tissue to our pathologist, the pathologist will report on a few things. First and foremost, they will say whether there is a adenocarcinoma in the prostate or not, number one. Number two, they will tell us if it really is an adenocarcinoma or the other rarer types of prostate cancer. Some of the rarer types of prostate cancer which are not adenocarcinoma can be squamous cell carcinoma and neuroendocrine tumors in the prostate, which are more aggressive and more dangerous. Adenocarcinomas are usually slow growing. Along with this, most importantly, the pathologist will grade the prostate cancer in the tissues. So this is called as Gleason scoring or Gleason grading. Essentially, it goes from 1 to 5. The grades go from 1 to 5, and the score, the Gleason score, is reported as a combination. The lowest possible combination that we can get from our pathologist is 3 plus 3, 6. Anything which is less than 3 plus 3 is not a valid report. We will have to discuss again with the pathologist, and we do not consider that as cancer. So the least score is 3 plus 3, 6, and the highest score is 5 plus 5, 10. So 3 plus 3, 6 means it's a very low cancer. 5 plus 5, 10 means that it is a very aggressive cancer. Along with this, the pathologist will also tell us some other features like how much percentage of the biopsies are involved by the cancers, whether there is a lymphovascular invasion in the tissues. These help to prognosticate the patient and tell the patient really how aggressive or not aggressive the cancer is. So now that we have done the digital rectal examination, we have done the PSA blood test, we have done the biopsy, transrectal ultrasound biopsy, and it has been confirmed by our pathologist on histopathology that there is a adenocarcinoma of the prostate. I'll be sticking with adenocarcinoma because it is the most common form. So along with this, we know the Gleason scoring and how aggressive or non-aggressive the cancer is. So what happens next? Just like every other cancer, the treatment depends on the staging of the disease. So in prostate cancer, after the biopsy has confirmed it, there are various imaging studies available to exactly stage the disease. Most of the guidelines still have CT scan and bone scan as the tests which are usually done to diagnose the disease. MRI nowadays is mostly done for localized staging. What that means is whether the cancer is seen only in the prostate or it has spread outside the capsule of the prostate, it has involved the neurovascular bundles around the prostate, or if it has gone into the bladder neck of the prostate. So MRI is now a more commonly done investigation. Bone scan is still extremely widely done. Unfortunately, it gives information only about the bones, whether there is any metastasis in the bones from the prostate cancer. More and more patients, more and more centers, more and more urologists and uro-oncologists have all shifted to doing PSMA PET-CT now. Though it is not part of the guidelines at the moment, it has already been there in India for almost a decade now. And we as uro-oncologists are exclusively dependent on the PSMA PET-CT. So the PSMA PET-CT is prostate specific membrane antigen tagged PET-CT. Essentially, it goes and binds to cancer cells in the body wherever they might be, and the image lights up on the PET-CT. So if possible, if the patient is affordable, definitely PSMA PET-CT should be the investigation of choice for a distal staging of the prostate. If the patient is a low stage 1 or 2, where you might be considering surgery or radiation therapy, I'll come to the treatment in more detail in a while. Then MRI also is a very good investigation to know the local staging. So nowadays, 3 Tesla MRI is usually the standard of evaluation, or you can do it with a 1.5 Tesla machine with an endorectal coil, but that's more difficult and needs an experienced radiologist. So usually these prostate cancer lesions appear as hypo-intense lesions on T2 weighted images in the MRI. Like I said earlier, they are extremely crucial to identify the local extent of the disease, whether the cancer has involved the seminal vesicles, whether it has involved the surrounding neurovascular bundles, or whether it has involved the bladder neck. And it also gives us good information whether there is any metastasis into the pelvic lymph nodes, that is the lymph nodes around the prostate and the bladder, or whether there is any bony metastasis to the pelvis and the lower spine, and also the femoral bones at the head of the femur mainly, which is the common set of metastasis for the prostate cancer. Nowadays, we are doing what is called as MP-MRI or multi-parametric MRI. So this is now the standard of care or the standard imaging which is done for a local staging of the prostate. Essentially, it involves 3 components. There is a dynamic contrast enhancement called DCE. There is an MR spectroscopic imaging, and there is diffusion weighted imaging or DWI, along with the T2 weighted imaging in a 3 Tesla machine. So they use all these 4 factors to report the radiological image of the prostate, and essentially your radiologist will give you a scoring system which is called as PIRADS, PIRADS. Just like breast cancer has BIRADS, BIRADS, prostate imaging has PIRADS, which is prostate imaging and data reporting system. So this again is a score or a grade. It goes from 1 to 5. If the report says PIRADS 1, what that means is the chances of this patient having a prostate cancer on MRI is highly unlikely. If it goes and gets reported as PIRADS 5, what that means is there is a very high chance, or it is almost confirmed, that this patient has a prostate cancer. The lesion that you suspect is most probably a cancer of the prostate. So once with all this is done, finally we reach the final stage of the investigation and the metastatic workup. I'm sorry for the cramped slide. Just like most other cancers, it is graded according to the TNM staging. T for localized disease or localized extension, N for the lymph nodes, and M for the metastatic disease. So T1 essentially means the tumor is not apparent clinically. You cannot feel it with your finger while doing a digital rectal examination, or it is not visible on any imaging. More often than not, T1 is when a TRP has been done for suspecting a benign disease. A transurethral resection of the prostate has been done suspecting a benign disease, and that gets reported as a adenocarcinoma of the prostate. Usually that falls under T1 category. T2 is when the tumor is confined within the capsule of the prostate. It can be there in one or either of the lobes, but not gone outside the capsule of the prostate. T3 essentially means it has gone outside the prostatic capsule, or it has involved the surrounding structures like the seminal vesicles or the neurovascular bundles. T4 is when it has gone even beyond that, and it has involved the external urethral sphincter or the rectum, which is posterior to the prostate, or the bladder or the levator ani muscles, or even the pelvic side walls. N is the lymph node staging. Obviously, N1 means involvement of the pelvic lymph nodes, which are the lymph nodes which drain the prostate and the bladder. So these pelvic lymph nodes can be internal iliac, external iliac, obturator, and the presacral nodes, nominated as HOPE, HOPE nodes. Usually these are the ones involved by the spread in the prostate cancer. M is metastatic disease. That again is graded depending on how distant the mets are. So TNM staging is mandatory. So only after we reach this stage can we plan the treatment of the patient. So up till here, all the investigations that I just described are necessary. Imaging either in the form of MRI for localized disease, particularly if you're suspecting an early disease, is important. For distant staging or metastatic workup, the investigation of choice right now is a PSMA PET CT, but if it is not available, then a bone scan is also a good option. So let's move on. Let's diverge a bit for a couple of slides. So let's just talk about screening for prostate cancer. I was just saying that there are no symptoms in a prostate cancer. So what do you do when a patient comes to you for something else? So is there a role for prevention in prostate cancer? Absolutely yes. So that is where the role of screening comes in. So screening for prostate cancer is done with the help of the PSA blood test. So while there are no concrete government or association guidelines in India, abroad, this is the pattern that it is followed. Beyond the age of 40 years, every male who comes to any doctor should be subjected to a digital rectal examination, which is absolutely crucial. And a PSA, prostate specific antigen blood test, is absolutely mandatory for every patient who comes to you, regardless of what he has come for, beyond the age of 50 years, once a year. And if there is a family history of prostate cancer, then this one yearly screening of PSA has to be done from the age of 45 years. Since this is an important slide, I'll just recap. It does not matter if the patient has come to a urology OPD or a surgery OPD or any kind of OPD. If the male patient has come to you and he is more than 40 years, it is absolutely mandatory to do a digital rectal examination, number one. If the patient is more than 50 years, it is absolutely mandatory to do a PSA blood test once every year in that patient. If there is a history of prostate cancer in the family, from the age of 45 years onwards, we have to do PSA blood test once a year. So this is called as opportunistic screening. Though there is no concrete guidelines, this is probably the best clinical pattern that we can follow in all our Indian patients. The reason why screening is so important, and I spent a couple of extra minutes on that slide, is to get to this slide. What this slide is saying, that the survival rate or the overall survival rate at 5 years in a patient who has been diagnosed with prostate cancer when it is localized. When the prostate cancer is in an early stage, stage 1 or stage 2, then the chances of 5-year survival is 99%. But if the prostate has cancer has been diagnosed after a late diagnosis and it has become metastatic, then look at the chances of 5-year survival. It has become 1/3. It's only 31%. So that is a huge difference. So this is the reason why screening and why examination of all men at the appropriate time becomes extremely important. Let's move on to the final bit, which is the exact treatment of prostate cancer. So this is the most important point I would like you to remember, that the treatment depends on the stage of the cancer. So many times we use more than one treatment. The higher the stage of the cancer, more the number of treatments that will be used. So let's go through these treatments in brief, one by one. So there is what we call as active surveillance, which can be used for some patients, selected few patients with very early stage cancers. There is surgery in the form of radical prostatectomy. I will get to that in a minute. There can be radiation therapy, hormone therapy. Hormone therapy, I think everybody knows this about prostate cancer, that hormone therapy is the bedrock of prostate cancer. Dr. Higgins won the Nobel Prize for the discovery of hormone therapy in prostate cancer. So I think everybody knows about this. But hormone therapy is not a blanket treatment for all cases of prostate cancer. It can be dangerous when used when it is not indicated. I will get to that in detail after a few slides. Chemotherapy, immunotherapy are also very valid treatments right now. Some of the other rarer treatments can be focal therapy, where we use radiofrequency ablation or cryotherapy, or HIFU, which is high intensity focused ultrasound, to destroy the cancer cells when it is a very localized disease. However, focal therapy, which is becoming popular around the world, but as of yet, the results have not been on par with the other standard treatments, which is why I have left a gap in the slide between the regular well-accepted treatments and some of the other treatments below. So the latest treatment for metastatic disease right now is what we call as theranostics, which is done by our nuclear medicine experts, where PSMA tagged lutetium therapy is gaining a lot of traction. However, the data on this is quite less at the moment, and usually it is used as a Hail Mary option when the patient has exhausted all the above options. So lutetium therapy is usually used as a last resort. So let's go into the details of these treatments one by one. I was just talking about active surveillance. So essentially, it's a way to monitor a very slow growing, very early stage prostate cancer. And it is appropriate when the treating the cancer would actually cause more discomfort to the patient than the disease itself. What we have not realized till now is that adenocarcinoma of the prostate is an extremely slow growing disease. So though it is slow growing, it can be fatal, but in a few very selected patients, very elderly gentlemen who you think do not have long to live or who are very unwell from various other conditions, in those men, active surveillance can be a good option, not otherwise. The patient should be highly motivated for active follow-up, for multiple biopsies, for repeated imaging to monitor the cancer. Only if all these criteria are followed, only then the patient is the candidate for active surveillance. For all these reasons, active surveillance, though practiced widely in the West, has not really taken off among our patients, which is why. So this is the most important slide in my presentation. So this is treatment as per stage. I have tried to keep this brief and just kept it very minimalistic. So when the prostate cancer is stage 1 or stage 2, then we always try to treat the patient with a curative intention, meaning we use surgery, that is radical prostatectomy, or radiation in order to completely cure the patient of prostate cancer. And usually in stage 1 or stage 2, the chances of curing the cancer completely is more than 90 to 95%. So that is quite good. In stage 3 or oligometastatic stage 4, what I mean by oligometastatic stage 4 is that there are less than 5 sites of metastasis in the patient. Though it is stage 4 metastatic, there are less than 5 metastatic sites. So this is very early stage 4, also called as oligometastatic stage 4, or stage 3, where it is locally advanced. In these kind of patients, multimodality therapy, I told you earlier, as the stage increases, the types of treatments become more and more. So in stage 3 or oligometastatic stage 4, multimodality therapy is usually done. This can involve surgery, radiation, and hormone therapy. So the choice of all these things have to be tailored to the individual patient. However, once it is polymetastatic stage 4, a prostate cancer patient with excessive metastasis to multiple bones, to the lungs, to the liver, anywhere else, this becomes polymetastatic. Here, hormone therapy is always the foundation of the treatment. And always hormone therapy has to be given with either chemotherapy or one of the newer anti-androgens. Let's remember this. This is very important. So in polymetastatic stage 4 disease, earlier most of us would do, let's say, bilateral orchidectomy for the patient and then be done with it. But it is very clearly proven now that just by doing orchidectomy or with hormone therapy is not going to be enough in a polymetastatic stage 4 disease. You always have to give another line of treatment along with the hormone therapy, and that can be chemotherapy or one of the newer anti-androgens. Another important thing to remember, I just covered this, is because prostate cancer spreads extensively to the bones. So bone strengthening agents and monitoring of these agents is also mandatory. The most common bone strengthening agents we use are zoledronic acid, which is usually given once every 3 months, or denosumab, which is a rectal inhibitor, which is also given once every 3 months. The final stage of this is castration-resistant prostate cancer, or CRPC, which is the final stage of the natural progression of the disease. Here, almost all the same agents are used as polymetastatic stage 4, with a few other options of immunotherapy, and the latest ones are called as PARP inhibitors. So surgery is always radical prostatectomy, and it can be done either open, laparoscopic, or robotic. Worldwide, the maximum number of robotic surgeries done anywhere in the world are all for prostate cancer. So robotic surgery has mainly taken off across the world because of prostate cancer and radical prostatectomy. So in this surgery, usually the whole of the prostate outside the capsule, along with the seminal vesicles, the neurovascular bundles, and the surrounding pelvic lymph nodes are removed, which is called as an extended pelvic lymph node dissection. In a few younger patients or very early disease, using the advantages of robotic surgery, the magnification, etc., we are able to preserve the neurovascular bundles so that the patient has a better urinary incontinence rate and also some erectile function, because these are the two most common side effects of this surgery. So next is radiation therapy. We all know that it uses high energy X-rays to destroy the cancer cells. There are various forms of radiation therapy also. So usually external beam radiation therapy is when it is given from outside the body. Brachytherapy is when radioactive pellets are inserted into the prostate. But the latest and the better one now is called as intensity modulated radiation therapy, or IMRT. Here, the main advantage is that there is a focused dosage of radiation. Earlier, with external beam, the radiation would hit a lot of the surrounding structures around the prostate, especially the rectum and the bladder, and would produce various significant side effects in the long term, which are radiation cystitis and radiation proctitis. So these days, IMRT has been a significant jump. And just to be open and honest, the chances of curing the cancer with either surgery or radiation therapy in stage 1 or stage 2 is exactly the same. Both do a fantastic job, and both offer the patient a chance to be completely prostate cancer free. I was also talking about hormone therapy or androgen deprivation therapy as the foundation of treatment of prostate cancer, particularly when it is stage 3 or stage 4. So we all know that prostate cancer is dependent on androgens for its growth. It's food for the prostate cancer cells. And the logic is to block the production or the action of androgens. So just take a look at what I have marked in red on this slide. I said earlier that androgen deprivation therapy can also be dangerous. So testosterone is very important for men to maintain various other things, even after menopause or andropause. So testosterone has a very significant function on the heart muscles as also the bones. So which is why hormone therapy or androgen deprivation therapy should not be offered to any patient in stage 1 and stage 2 prostate cancer. I hope you remember this very clearly. Hormone therapy should never be offered to anybody in stage 1 and stage 2. It is only for advanced stages, stage 3 and stage 4. So this hormone therapy can be achieved either surgically by orchidectomy or through medications, which are usually injections. So chemotherapy also is a very important treatment modality. The most widely used one is docetaxel. 6 cycles of docetaxel chemotherapy is the standard for prostate cancer. However, it is only used in advanced or extensive metastasis or polymetastatic disease in stage 4. Some of the other chemotherapy agents which have gained a lot of traction are cabazitaxel and doxorubicin and paclitaxel. So it is extremely important to choose the right option. It is very important to tailor the treatment according to your particular patient, the patient sitting in front of you. Remember that one size does not fit all. This is very important in prostate cancer treatment. We have to take multiple factors into account to treat a particular patient. So thank you for your attention. So stay healthy, stay happy, stay safe, stay protected from COVID. Thank you. I'll be happy to take any questions from the audience or the organizers.
Yeah, thank you very much, sir.
Yeah.
So there are no questions till now, but can you
Okay.
wait for 1 2 minutes more for the delegates if any questions comes?
Yeah, yeah, absolutely.
Mm, thank you.
Again, apologies for forgetting to share the slide for the first few slides. If you want, I can just go through the first few slides. Do you want me to do that?
Yeah, I mean, if you want to share from your end, if you want to,
Yeah, there's nothing special in the first few slides. So just my bio and just the epidemiology. I just wanted to show this just to reiterate the fact that prostate cancer is becoming extremely common in India, not just in the West, in India. Right now, according to the latest studies, the latest data, it is the second most common male cancer in Bangalore and by extension, most of the metros after oral cavity cancer in men. So we should be worried, and also it is the sixth most frequent cause of cancer related death in men globally. So the idea that prostate cancer is very slow growing, does not need any kind of treatment is absolutely false, because if it progresses, then it can even cause death of patients. So this was just to say that the older a male becomes, the more and more chances of him having prostate cancer. Some of the risk factors, I just covered this, nothing specific as a risk factor for prostate cancer. Symptoms, I said initial stages, there will be absolutely no symptoms. Some in the advanced stages, patients usually present with bony pains. They can even present with spinal cord compression or spinal cord vertebral fractures, and even with paraplegia. So digital rectal examination, I said, was very important. Any patient above the age of 45 to 50 years who comes to any OPD, let alone urology or surgery or any OPD, digital rectal examination is absolutely mandatory. Through that, we can feel the surface of the prostate. There can be some hard nodules or an uneven consistency, which can be suspicious for malignancy. Most importantly, after that, we have to do the PSA, or the prostate specific antigen, which is the most important blood test for prostate cancer. After that, we send the patient for biopsy to our urology or intervention radiology friends. So I think till here I started, from here I started projecting or sharing the screen. So before this, I just missed it. Yeah. I'll just move it to the slide that I think is the most important one. Yeah, this one. So this covers the gist of my talk. I would probably say this is the most important one after the PSA screening. So just to reiterate, stage 1, stage 2 prostate cancer, surgery or radiation therapy with a curative intent are very good treatment options. Chance of curing the patient from prostate cancer is more than 90 to 95%. When it is stage 3, also called locally advanced or oligometastatic, where the number of metastasis is less than 5, or also called early metastatic disease, then multimodality therapy, which involves surgery, radiation, and hormone therapy if needed, become the treatment of choice. When it is extensively metastatic or polymetastatic stage 4, then hormone therapy is the foundation of the treatment. Always, it is always given with either docetaxel chemotherapy or one of the newer anti-androgens, which are called as abiraterone or enzalutamide. Both of these are tablets. So please remember that when it is extensively metastatic stage 4, we have to give hormone therapy plus chemotherapy or newer anti-androgen agents. Also in this stage, because prostate cancer spreads excessively to the bones, bone strengthening agents in the form of calcium supplements, zoledronic acid, and or denosumab are absolutely crucial. So the final stage of prostate cancer as a natural progression is called CRPC, or castration-resistant prostate cancer, when the cancer continues to grow in spite of the patient having taken all the above treatments. In such a scenario, along with the same options as stage 4, the options of immunotherapy and PARP inhibitors, which are the latest thing in prostate cancer, the most common drug being trialed is olaparib. These become the treatment options. I guess that covers most of the things. Yeah, so I'll be happy to take any queries right now.
Yeah, so still there are no questions. People are just commenting on your webinar on this
Okay.
presentation. Yeah. Also, they are giving you greetings.
Okay. Thank you. Thanks to everyone. Once again, I apologize for the initial non-sharing of my screen. So I hope I covered the first few slides again. Any questions, I'll be happy to answer them, either from a general practitioner or a general physician perspective, or from any urologist or urology residents watching. Please feel free to ask me any questions that you would have. Please remember, no matter where you're practicing, no matter at what level you're practicing, always get a PSA blood test after the age of 50 years in all your male patients, all your male family members, all your male relatives, all your male friends, once a year after the age of 50 years. That is the only way to hopefully catch prostate cancer in an early stage, and it can be cured. Once it crosses stage 3 or becomes stage 4, it is impossible to cure a prostate cancer. It becomes all about control, which is why early detection is extremely important. Other thing to remember, please ask or please be careful before starting hormone therapy in any of your patients. There are very specific indications to use hormone therapy. It is dangerous in itself. It can itself cause deaths of many patients, not from the cancer. The hormone therapy can kill the patients. So please be careful before advising or starting any kind of hormone therapy. It should only be used in locally advanced or metastatic prostate cancer. I think these 3 points were the most important points in my talk. I hope most people have registered that.
Yes, so no questions there. So, with your permission, shall we conclude?
Yeah, sure. Absolutely. I'll be happy to answer any questions by text or WhatsApp later if anybody has questions.
Yeah, thank you very much, sir. So, with your permission, shall we wind up?
Thank you. Thanks so much.
Okay, thank you, thank you, thank you. On the behalf of organizer, I would like to thank you for your insightful and educative talks. Thank you very much.
Thank you so much. Yeah.